Thank you very much, and again, thank you for staying till the end. I'm Max Kotler, Chief Operating Officer and President of GelMEDIX. We are developing a hydrogel platform for improving the way drugs are delivered to the eye and across the body. Our lead asset is in cell therapy and RPE cell therapy for GA. The people on the panel, including Mark and Brian, did a great job at explaining the potential benefits of RPE cell therapy, where they really have seen visual benefit in both patches and in suspensions. But we think there's some fundamental limitations in the formulation of cell therapies, and we're seeing what happens with that in the clinic. So for example, in now multiple trials from different sponsors with suspension-based approaches, we see that the cells tend to efflux out into the vitreous and cause an epiretinal membrane. This is probably inherent to the fluid dynamics and the pressure differences between a bleb and the vitreous. And so what we wanted to do is create a product platform that can solve this problem and bridge the gap between the benefits of patches and the benefits of a suspension-based injection. What we do is combine iPSC-derived RPE with our proprietary hydrogel precursor. This is a gelatin-based polymer that is cross-linked with white light, very similar to what Retina does, except we have a different chemistry. We do a subretinal injection just like everyone else would do, same CPT code, same subretinal devices. The difference is we then cross-link that material by transiently increasing the intensity on the endoilluminator that's part of a 3-port vitrectomy for about 60 seconds. So that's really the only difference you have between what we're doing and the standard suspension-based approach. So just putting that light there to cross-link that gelatin. And what we have now is a localized depot of cells that are not escaping into the vitreous, and they have a matrix to form their monolayer. And I'll go into what we're seeing with that. We do see that our cells are of high quality. They express all the right proteins and genes as we'd expect, no residual pluripotency. They maintain their cuboidal shape and pigmentation. When the hydrogel is there, it's degraded in 5 days. So this is after the gel's gone. And I know Mark will ask, we did check PET-F, and it is apically secreted after the gel is gone. So we don't see a change in the polarity of the cells. We have recently been working in a rabbit model of GA using sodium iodate to degenerate the retina. What we see is that from a histology point of view, really nice preservation of the ONL because we have an intact RPE monolayer of transplanted human cells. So if you start on the far left, this is 38 days after sodium iodate, 37 days after the treatment. We see there's an RPE monolayer there, and if you look at the panel below that, it's stained purple for stem 121. So these are human cells in a monolayer, and we see the rabbit photoreceptors are tightly packed. We even quantified this and showed that they are more densely packed than if you treat with the same cells in a suspension or don't treat at all. And so we're really excited about this, and you can compare the histology here too to when we use the same cells in a suspension or don't treat at all, and we see really clear degeneration that is not seen when you use the hydrogel formulated RPE. We also wanted to do more imaging to really sort of look at what would happen in the clinic as a real outcome. So we see on OCT, again, a preservation of the ONL. Quantified over the 38 days, we see less ONL loss when the hydrogel RPE formulation is used compared to the cells alone. We also see a better monolayer on OCT, and we can see clear maintained or repigmentation on fundus at the bottom. And I think really excitingly, we didn't expect this, but in full field ERG, we actually saw all the eyes that were treated with the hydrogel and RPE have a bounce back in the A and B waves post-sodium iodate versus 50% when the suspension was used. So what we're really seeing is that the hydrogel gets better RPE function because they have that structure, leading to better photoreceptor structure, leading to better photoreceptor function. So really it's a clear demonstration of structure but gets function in the retina, which we all know is the core to anatomy. We also have a platform. We can put in photoreceptors, endothelial cells, and other things. We've recently been able to demonstrate that we can inject this polymer as a liquid suprachoroidally and then cross-link it with white light through the sclera, same intensity that you can get on a slit lamp. So what this would allow is a sustained release product in the suprachoroidal space that is in situ forming and non-swelling, so it doesn't risk the spike in IOP from a swellable polymer. We also have shown that this reduces viral aggregation and can prolong viral release and improve transduction. We'll have a lot more data at a poster on Tuesday afternoon. We're currently raising a Series A of 10 to 12 million, or up to 40 to reach clinical proof of concept, and really excited to talk to partners. So thank you again for staying here.
Excellent, thank you.
Yeah, well, great anticipation of my asking the growth factor question, but and I think it's a very clever way to, and your obviously your histology looks good to get the monolayer and potentially deliver other drugs. So my question to you is, and we were asked this by the agency, is that what if these cells become malignant and they're all over the place, there's no scaffold? What are you going to do? See, when you have a scaffold and the cells become malignant, you can remove the implant, but if there is no scaffold, I mean, you can think about it. I guess we could go around laser all the pigmented areas, but it becomes a sort of a challenge. So I think for cell-based therapy, you were able to clearly achieve the monolayer and get rid of the scaffold, and it looks like it's good survival. But then there's this other question, and secondly, I think in AMD, since Brooks membrane is compromised, unlike in the sodium iodate rabbit model, it's going to be interesting what happens without the scaffold. But I think it's great work. I think it's great that you can get it monolayer polarized and get all the growth factors to elute.
Great, appreciate the question and the insights there. I think you're right about Brooks membrane. That's why we thought providing a matrix that is made of collagen or collagen-derived material is important, because RPE cells clearly need that, and all epithelial cells do. So we do see collagen production, so I think over time it could be replenished. Very interesting question on the side of malignancy. I think doing the proper tumor genicity studies in animals and doing the right QC on the residual pluripotency on the cells, as well as ddPCR and other things to look for potential gene changes, is the way to mitigate that. I think also I'd be interested in the removability of the patches if there's foreign body reactions over time. So I think regardless, it's always going to be a challenge. But in these patients, the option is that or not seeing. So I think the benefit is there.
Thank you very much. Appreciate it.